Welcome to 50 Plus in Montgomery County, a monthly show produced by the Commission on Aging. Each episode, we look at issues of interest to older adults. My name is Jean Dinwiddie. I'm co-chair of the Commission's Communications Committee. I'm subbing in for our regular host, Commissioner Katie Smith. On this month's show, we are going to explore end-of-life choices. And joining me is Diane Rehm, author, journalist, and advocate. Many of you may recognize Diane from her show from NPR, the Diane Rehm Show. Diane, we are so delighted to have you here today to chat with us.
Thank you so much, Jean. It's good to be here.
If we could start, could you tell us really what had you become an advocate for end-of-life choices? Tell us about your husband's story.
Well, I think even before my husband's death of Parkinson's disease, he and I had talked a great deal about what each of us would wish to have at the end of life, and that is a peaceful death surrounded by family without tubes and wires and ventilators, and certainly to be able to die at home. Jean Rehm had Parkinson's disease, and when the time came, he had to move into a nursing home. He had been there for about a year and a half, and finally he could no longer feed himself, he could no longer dress or toilet or shower himself. And he said, "I am ready to die." Now, in the state of Maryland, where he was, of course, that's not allowed. It failed by one vote when I testified before the Maryland House of Delegates, as I also did before the Massachusetts House of Delegates, in favor of death with dignity. In other words, giving individuals the choice, if they are within 6 months of death, as deemed by two physicians. And that is exactly the case with my husband. So when medical aid in dying was not available to him, he chose to starve himself to death. It's called VSED, voluntary stop eating and drinking. And it took 10 long days, Jean, for him to die. And I certainly don't want that for myself or for anyone else who wishes to have a peaceful, quiet death with families surrounding them.
So I'm so sorry to hear that, and I'm sorry that it was just one vote. I noticed you used the term medical aid in dying. Is that the right term? I've heard assisted suicide and other terms.
Well, you know, opponents argue it is medical aid in suicide. Suicide and medical aid in dying are so different, Jean. People who commit suicide may have years to live, but they choose to take their own lives. People who wish to have death with dignity or medical aid in dying have no choice. They are dying. They are within 6 months of death, and they want to have a peaceful, quiet ending surrounded by relatives. I talked to one woman in a film we did called When My Time Comes. She was 37 years old, and her breast cancer had spread to every bone in her body. And she said, if I had my druthers, I'd live until I was 90. She said, but I know I don't. And I don't want my 13-year-old son to see me suffer the way I watched my own mother suffer and die.
You mentioned the PBS documentary, When My Time Comes. That's also the name of your book.
Indeed.
So you said you started the conversation with your husband well before his death. How do you? That's such a difficult conversation. How do you start it?
Well, each of us had deaths in our family. My mother died at 49 when I was just 19 years old. My father died 11 months later, literally of a broken heart. John's mother committed suicide at 92. His father took his own life at 73. So death was around us, and therefore we were able to talk about it with our young children. They knew what had happened in our own lives, and they knew what we wanted for ourselves.
So it's making your family aware. You just start the conversation by starting it, I suppose.
Absolutely. And if you are the child, for example, as many baby boomers are now facing their parents who are going way into old age, something as simple as, Mom, I've been thinking about my own life. Here I am at 60 or 50 or whatever, and I've been thinking about what I'd like the end of my life to be. And I would start talking about what I wanted and then shift and say, have you thought about this at all? Is there something you'd like me to know about what you would like at the end of life? I think that's an easy way to get into it. And it's not just one conversation, Jean. It is many conversations. As you can imagine, there are those, and it means many of us who simply don't want to talk about death. And if we can begin those conversations and literally find out whether your mother or father says, I'm going to leave it all in God's hands, then your child knows that that's what your parent wants. Or perhaps your parent says, I want everything medical science can provide to keep me alive. Again, you know. And if your parent says, I'd like to go peacefully in my own bed without the accoutrements that medical science can offer, if I know I'm dying, I'd really like to go peacefully here at home with you, the grandchildren, and friends.
And then so you make your family aware. I mean, in my case, it would be making my children aware. And then what's the next step then?
To talk with your doctor. And if you're living in Maryland, you've got a problem because Maryland still does not have medical aid in dying as part of its law. When we began filming, there were only 3 states with medical aid in dying: Oregon, Washington, and Colorado. Now there are 10 states plus the District of Columbia. So, if you're lucky enough, fortunate enough to live in one of those 10 states, talk with your doctor, tell her what it is you want, how you'd like to be treated, and how you'd like to go out peacefully, or whether you want everything possible, or whether you want God to be the decider. But talk about it, and talk with your neighbors, talk with your friends, talk with everyone who means something to you, so that they will know what it is you'd like to have at the end of life.
And then I imagine getting your advance directives in place would be very important as well.
However, there are times, depending if you call 911 and you are living in a state where medical aid in dying is not permitted, if you call 911, the obligation of those people who come to your home is to try to revive you. Even if you have a notice on your refrigerator that says DNR, do not resuscitate, they do not necessarily pay attention to that. And if you are taken to a Roman Catholic hospital and your wish is to have no intervention, I fear that that will not be paid attention to either.
So a lot of important lessons there. Diane, where can we learn more?
Compassion and Choices is the organization, and you will learn what you need to do to prepare yourself. And the very best information can be found there. I hope you can see the documentary, which is still available on Amazon.com, and read my book of the same name, When My Time Comes, which I began writing about 2 years into the filming process. So the film came first, then came my book.
Well, you have helped us, many of us, either start the conversation or continue the conversation. To your point, it's a conversation you have again and again. So Diane, thank you so very much for joining us today. I really feel like there's a star in our presence. We are so honored you joined us.
It was my pleasure, my honor to speak with you and those folks who live in the state of Maryland. If you want medical aid in dying, talk with your legislators, talk with your delegates. That's the only way you're going to finally get it.
We must be our own advocates.
Indeed.
Yeah. So thank you so much, Diane. We really appreciate your joining us.
Thank you.
Thank you. Up next, we'll talk with Ben Marcantonio, Chief Operating Officer of the National Hospice and Palliative Care Organization.
Our fight against coronavirus isn't over. Let's wear face masks in public, stay 6 feet or more from others, follow state and local guidelines, and wash our hands frequently. Let's move forward together. Learn more at coronavirus.gov.
Welcome back to 50 Plus in Montgomery County. Hello, Ben. Thank you so much for joining us today.
Hello, Jane. It's a pleasure to be here. Thank you for having me.
Well, we are really interested in talking about our end-of-life choices. So I know you're with the National Hospice and Palliative Care Organization. So tell us, what's the difference between hospice and palliative care?
So hospice is a form of palliative care. It's one important service within an umbrella of palliative care. So in the broadest sense, palliative care is person-centered, whole person care. So really looking at every dimension of our human experience with illness, especially in the context of illness, life, quality of life, and death and dying. So it's about bringing comfort, diminishing symptoms that create pain and discomfort from that whole person care perspective. And palliative care can be delivered by a physician, a nurse practitioner, a social worker, a chaplain, or the coordination of those cares overall, and caregivers overall. And should be taking place earlier in the experience of serious illness, actually from time of diagnosis with a serious illness. Whereas hospice then comes in as the progression of that illness evolves and it's becoming apparent that there's decline and end of life is near, that supporting quality of life and pain and symptom management in a more intensive but still comprehensive way through all those disciplines, really working as a consistent team together around and surrounding that patient, in our terms, patient and family, or a network of caregivers who are supporting those individuals.
So you mentioned a team. Who's on the team, on the hospice team and on the palliative care team?
Right. On the palliative care team, typically it's a physician and or a nurse practitioner along with a social worker, a nurse. It's a little, it's generally a little slimmer in terms of the number of people involved at a given time, and maybe a little more intermittent, but all that multidisciplinary nature is still very important to the care. The hospice team typically works together on a very consistent basis, day to day, week to week, as a hospice team. Always includes a physician who helps lead and guide the clinical dimension of care, along with a nurse case manager who is assigned to that case to oversee the plan of care, but always integrating and incorporating the psychosocial dimension through a medical social worker role, an individual who's part of that team, again, working consistently where they know each other and really work in concert with each other on a day-to-day and week-to-week basis. Also spiritual care and a certified home health aide. Also on a hospice team that's very important is the volunteer role. And these are all defined as requirements in the Medicare hospice benefit, which is also then incorporated into any other insurer that covers or supports hospice care.
How does a person qualify for hospice?
Hospice eligibility is based on clinical need and assessment of a physician who is right now, it determines that the course of the illness is taking a course where the prognosis is that the end of life would be 6 months or less. That based on that clinical assessment and judgment of the physician, that a person has 6 months or less to live. That's how the Medicare benefit is currently designed and the requirements are laid out.
So Medicare pays for hospice?
Correct. Medicare covers hospice as part of its overall benefit. And right now it's structured such that it's a separate benefit apart from Medicare Part A or B. And so when one elects the hospice benefit, you get all your hospice care needs covered under that, and the provider is reimbursed through that. an individual who's on hospice could still access Medicare Part A and B for other needs apart from their
Okay.
hospice diagnosis. But that's what the hospice benefit covers, that for individuals.
And how about palliative care? Does Medicare pay for that?
The main mechanism for payment for palliative care right now is through outpatient billing services. So a physician or nurse practitioner, and to some degree, social work can bill, I believe social work can bill for visits done and assessments and medical conversations, goals of care conversations that drive the care for that individual. But we billed under Medicare Part B, and that provider is reimbursed by Medicare in that way, and also other insurers in a similar manner.
And you said that you have to elect the hospice benefit. So when we're signing up at open enrollment, we need to choose a hospice benefit if that's what we want?
It would really only come into play when a doctor refers an individual to hospice.
Okay.
And at that point, the conversation would be, this is the stage of your illness, your doctor is recommending, or the doctor would have this conversation, or a hospice member. And so this is your option. This is what a hospice does. This is the kind of care is provided. Do you want to elect this benefit and sign on?
Okay. All right. So it happens at the time. And that was one of my questions is, if I know I'm towards the end or a family member is towards the end, do I need to find hospice, or will my doctor know how to find that?
Really important question. People come to hospice in a number of different ways, very frequently through physician referral. So your primary care physician, or maybe a specialist, an oncologist or a cardiologist, might make the referral and recommendation for the individual and or family members to talk with a hospice provider or a palliative care provider for a palliative care consult, because they may feel like maybe just a palliative consultation is needed to discuss the possibility of palliative care or hospice care, and depending on what stage a person is in their illness. So what's really important about it is the conversation, and really that person's goals for their care driving their own decision making, and the providers being there to provide the information needed to make a good, well-informed decision for their care.
So it's about our previous guest, you may know Diane Rehm. We talked about starting the conversation and how important that conversation is, and how important it is to make your own wishes known.
Absolutely.
And I understand there are several tools there available for making your wishes known. Where is there a place you would direct our viewers to, a website or?
Sure. Well, the first thing that comes to mind for us, because it's part of NHPCO's resources, is our Caring Info website. So it's www.caringinfo.org. Has a wealth of information about palliative care, hospice care, serious illness care, and where those resources for advanced directives, living wills, things like that, just to explore options and resources there. So I would first point to that. Many individual states have websites as well. So regardless of what state you're in, you might want to go to your Department of Health Services website for your particular state, particularly around how they handle advanced directives, because it is a little bit different from state to state. So that would be another recommendation for exploring that.
So we talk to our families and we talk to our doctor. So I've been seeing my doctor for decades now. If I have to go into hospice, can I keep my doctor? You mentioned there's a team. Can I keep my doctor?
Yes, absolutely. In fact, we encourage people to keep that continuity of care with their physician, be it their primary care physician or, again, their specialists. Our team members as hospice and palliative care providers become a part of that larger team then, and sometimes the physicians will talk and one becomes more primary because of the area of focus, but that's done in coordination, again, always with the patient's wishes. Who do they want involved with their care and to what degree? So there's never any requirement, certainly, for anybody to leave their physician or give up that relationship.
All right, that is so good to know. So where are the services? I use the term go into hospice, but it's
Right.
not like I necessarily need to go to a, right?
Right.
Can it be, where are the services provided?
Hospice care is predominantly actually delivered at the where the person resides, so in their home, and that home might be an assisted living environment. It might be their own residential home that they've lived in for decades. It might be someplace they've just moved. It might be the home of a family member, or it could be in a hospital or inpatient care facility that a hospice owns and provides service through. So there are a number of different venues where hospice can be provided, but the majority of hospice care is done in homes or home-like settings, residential settings.
Oh, that is very comforting to hear, actually. And the whole team, including the spiritual support as well, is also very comforting.
Yes.
So tell me about afterwards. I understand that hospice offers bereavement services.
Yes, and again, that's actually built into the hospice benefit as an expectation that any hospice provider offers bereavement support for the family members involved with the care for a minimum of 13 months following the death of their loved one, that loss. Because we know that grief and loss kind of comes in waves at times, and those anniversary dates of birthdays, Father's Days, Mother's Days, all those things happen and can bring out the need for bereavement support. So that's why we bring it out to at least 1 month past the full cycle of a year. And those bereavement services can be offered in a number of ways by a hospice provider. It can be with group support, group counseling support offerings, individual grief and loss counseling. It could be through literature and bereavement pamphlets for people to use over time. So hospice providers provide that kind of care and support in a number of different ways. Some do all of those things, some do just some of those things.
I know we have, our show is primarily for older adults, but we also have caregivers out there. Can you talk to me a little bit about would a patient with advanced dementia qualify for hospice?
They often do qualify and are eligible for hospice care. Again, it's a clinical driven decision based on that clinical assessment. But again, if that whatever type of dementia that individual is experiencing and living with and through is demonstrating a decline of ability to for mobility, for swallowing, for anything that might inhibit their longevity and their quality of life would be evaluated as to whether hospice would be the appropriate support and care for that person at any point in their illness.
So given that 6 months
Correct.
prognosis.
Yes. And then palliative care would also be an option to be introduced to, again, minimize or to diminish those symptoms of discomfort, even if they're not quite eligible for hospice care.
Hospice yet. Okay. Ben, this has been really so informative, and hopefully everyone will start and continue the conversation, and really appreciate you joining us today. Thank you so very much.
Thank you for helping make this information available.
Oh, of course. Yes, it's necessary. Well, that concludes our program on end-of-life choices. We hope that the information provided is useful to you, and that if you haven't already, you'll start the conversation with your family and physician. To learn more about the many services for seniors in Montgomery County, please visit the Montgomery County Seniors website at montgomerycountymd.gov/senior, or call the Senior Resource Line at 240-777-3000.